to honor those people who've departed us. So anyways, let's move on and over to Dr. Girish. Thank you.
Thanks for the kind introduction, Maithili. So today, what we're going to do is going to be pretty informal, the session. I know that a lot of you over here are MBBS students. There are some faculty in other disciplines. But the way we will do the session is from a medical student point of view, with a little tidbits for all kinds of clinicians who may or may not treat lymphoma. So with that said, I will hit my share screen and let's take it from there. Share screen. Let's see there. Share. F5. Hopefully you can see the full screen, right? Okay.
Yes.
Yeah. Okay, good. So the topic for today is Hodgkin lymphoma. So this lymphoma is something that we all know, and we have all grown up reading. It's one of the first lymphomas that we ever get to know. A pretty easy lymphoma to diagnose. So as time has progressed in the past 20 years or so, there's a lot of things that have come that kind of look like Hodgkin lymphoma that we should be aware of, even as we see these cases. And so today's topic is going to touch upon some of those entities, even as we refresh our own knowledge of Hodgkin lymphoma biology and morphology for the most part. So the outline for today is going to be a discussion of Hodgkin lymphoma, classification, pathology, and it's definitely important for all of you to know. And then we will get on to the so-called diagnosis of gray zone lymphoma, which is something that is being recognized more and more often these days. And it has implications for treatment to be able to get to a diagnosis of gray zone lymphoma. And we will probably touch briefly on some of the other entities that stand around gray zone lymphoma that are not really gray zone lymphomas. And these are also things we should remember in the back of our mind before we look at these biopsies and as we look at them and communicate with clinicians as pathologists. So with that said, let's move on to some basic things. So as far as the learning objectives go, we will describe morphologic features of Hodgkin and the allied entities, including gray zone lymphoma. We will look at the literature to some extent on some of the newer entities that we will consider in the context of Hodgkin. At the least, you will learn the names of these entities in this talk, even though you may not go back and read the literature on all of these entities. And then we will come up with a very basic and a simple panel of stains that will help you get to a diagnosis of Hodgkin and also distinguish those mimicking entities. So this is a very simple goal we have here today. And we will get through all of this within the next 1 hour or so. So once I finish some of this talk, I have put in a couple of totally unrelated cases that are kind of spot the diagnosis moments. I would urge pathologists in the audience, full-time pathologists in the audience, not to take the question quickly, but rather I would want the med students to take their chances with that, and then we will give out the answers to other pathologists or other clinicians if need be. Okay, so history is always important, and I do like history to some extent. So we will start with the description of Hodgkin's provided by Thomas Hodgkin back in London when he was at Guy's and St. Thomas Hospital. He described his original paper back in 1832. I wrote 1844 earlier, but I realized it's actually 1832 when he described the original paper. And later, after the 1850s, Samuel Wilkes actually coined the term Hodgkin's disease, named after Hodgkin, even though Hodgkin per se did not call them Hodgkin cells. And then around in the 1890s and 1902, time went by, and there's this excellent physician at Hopkins, Dorothy Reed, and one more pathologist by the name Carl Sternberg. In a span of 10 years, they looked at these cells and identified these cells to be associated with this lymphoma. And of course, Dorothy Reed was key in saying that Hodgkin was not a form of tuberculosis. So that's important for us to know. And time went by. In the 1900s, most of the time, newer and newer classifications came by. I'm not going to dwell on all those classifications of Hodgkin lymphoma, but suffice it to know that in the late 90s, there was an increase in our knowledge with development of molecular techniques. And nodular lymphocyte predominant Hodgkin lymphoma, which I will describe in a couple of slides, was separated out in the German Hodgkin study group. And German Hodgkin study group is a huge group where they take a whole bunch of Hodgkin patients, and numerous studies have come out of GHS. And they separated out. And as our knowledge of microdissection of cells from tissues grew in the early 2000s, and 2005, rapid strides were made in molecular biology. And that led to better understanding of these gray zone lymphomas. And around the same time, other lymphomas by the name primary mediastinal large B-cell lymphoma, which I'll discuss in a little bit, was also described. So that happened in that time frame. And now we are at an era where the latest iteration of the WHO, hematopoietic tumors, has just come out in 2017. And there they add a little more lymphomas there with Hodgkin-like cells, but not quite Hodgkin lymphoma, that can mimic Hodgkin's, and the need to be aware of these entities. So this is a cover of the WHO, and sure enough, you can see that the Hodgkin cell does take a place in the cover of this book. So with that said, so this is the cell to the left that Carl Sternberg and Dorothy Reed described. That's Dorothy Reed to the right, and this Dorothy Reed Mendenhall. So that's that. And with that said, let's go into the classification of lymphoma in general. When we get to the classification of lymphomas, I tend to follow very simple rules. And simple, yeah. So I look at the tissue, and if there are few malignant cells here and there, and in a sea of what looks like just normal cells, then it's probably one of two Hodgkin lymphoma subtypes. Yeah, there can be some exceptions to that rule, but for the most part, this rule works. And if there are numerous cells there, that all of which are monotonous and don't look quite right for a reactive lymph node, then one of gazillion non-Hodgkin lymphoma subtypes is what I try to think. So this very simplistic classification will generally hold you in good stead. And it's reasonable to entertain a diagnosis of Hodgkin and work up things appropriately. So with that, let's move on into the era of few malignant cells. And so if there are few malignant cells, the next step is to look at the cells that are in there. And so to the left, you can see if the cell has really prominent eosinophilic nucleoli with thick nuclear membranes in a large cell with a phenotype on the three markers that I'm showing you here. CD20, which is a B-cell marker, being negative. CD30 and CD15 are two other markers, and if they are positive, then we get to a diagnosis of classical Hodgkin lymphoma. And then, if you have nuclei that look like potatoes, and there is hardly any nuclei. There's like 1, 2, 3, maybe 4 small nuclei with a really folded, crinkled nuclei. Then and it has a phenotype that's the exact opposite of classical Hodgkin. Then we are going to call it popcorn cells, or L&H, or lymphocytic and histiocytic cells, or LP cells, which is like lymphocyte predominant. Yeah, and these are the cells of nodular lymphocyte predominant Hodgkin lymphoma. And these are not called Hodgkin cells. I don't think any of the cases that Thomas Hodgkin originally described were nodular lymphocyte Hodgkins. And this is how it looks under the microscope, with sheets of histiocytes. And when you do the CD20 stain, you have what looks like a nodular cluster of small B cells. And here is membrane staining in the large LP cells that sit in the company of small B cell nodules. So this architecture is equally important as the phenotype of those cells that I am showing. A lot of lymphoma is really architecture and then the phenotype. So in this lymphoma especially, the architecture is critical. So that's important to remember. This morphology that I'm showing is important because there's a progressed version of this lymphoma that I'm going to show you later called T-cell rich large B-cell lymphoma. So when nodular LP goes bad, it goes into that lymphoma called T-cell rich large B-cell. There's a continuum right there. Despite all these differences, both these lymphomas arise actually from B cells. It's actually a germinal central B cell, and it's a highly mutated germinal central B cell. And some of that work was elegantly proven by Teresa Marafioti's group. And so this is the classification of Hodgkin lymphoma. Nothing much has changed. Hodgkin, classical Hodgkin, nodular lymphocyte Hodgkin on the right side. Yeah. And we have 4 flavors of classical: the nodular sclerosis, the mixed cellularity, lymphocyte depleted, and lymphocyte rich classical. So as far as the 4 subtypes go, nodular sclerosis is probably the most common, especially in the United States. And typically you will have a mediastinal mass, whereas the mixed cellularity is probably more common in India and is frequently EBV driven. And it has a mixed bag of cells, plasma cells, lymphocytes, eosinophils, and all that. The lymphocyte rich actually used to be confused with nodular lymphocyte predominant Hodgkin lymphoma. I know the terms sound very similar, but remember, lymphocyte rich is not the same as lymphocyte predominant in the lymphoma parlance. So you have to be careful what the words you use. Lymphocyte depleted Hodgkin is less and less frequent these days because many cases of lymphocyte depleted Hodgkin that people were calling out earlier actually turned out to be anaplastic large cell lymphomas, which are T-cell lymphomas. And the only lymphocyte depleted that we tend to keep within the realm of Hodgkin are the ones that tend to be EBV positive, and sometimes they occur in the setting of HIV. So there is some commonality between mixed cellularity and lymphocyte depleted in that respect. So with that said, how about some pictures of some Hodgkin lymphoma? So this is your typical classical Hodgkin lymphoma. It's such a high power that you cannot appreciate architecture. So if you want really low power, the very first slide that I told you, title slide, showed bands of sclerosis. But here you see a nice Hodgkin cell. These are histiocytes. This is blood vessels. And so this is 1 cell, 2 cell, 3 cells, maybe some 4 cells there, sitting in a sea of what look like numerous histiocytes. So all the pink in the background is coming from histiocyte cytoplasm. So this is your typical classical Hodgkin lymphoma. And these cells have a defect in their mitotic machinery. And so they cannot really proliferate, these cells. And these cells tend to mummify and die very easily. And that's why the nucleus sometimes becomes shriveled, and it's called a mummified cell. Yeah. And of course, we like to confirm the diagnosis with a CD30, which is an activation marker. The Hodgkin cells are strongly positive for CD30 right there. And one more marker we like to use is CD15. And Hodgkin cells here are expressing strong CD15. So for pathologists out there, when you're looking at CD15, I always like to use internal controls to determine if the immunostain worked well technically. And one way you ensure is to see if you can find high positive internal controls and low positive internal controls. And in CD15, you do easily find your high positive internal controls, which are your background neutrophils. Yeah. And your low positive controls that you want to look for are small cells like these. These are your monocytes. So once you see this range of staining, the weak and the super strong, then your CD15 is technically satisfactory, and you can believe the status of CD15 on these cells. Especially when CD15 is negative and it's important for diagnosis, I will make sure that the internal controls are okay. Because we get biopsies from all places, and you never know how they fix these tissues. If it's suboptimally fixed, your stains are going to be bad. And if your stains are bad, your diagnosis is only going to be as good as your stains. So this is CD20 on the same case. And you can see that your internal control, small B cells, are nicely positive, but the Hodgkin cells are pretty much negative or very weakly positive. So even though Hodgkin lymphoma was proven to be a B-cell lymphoma, it's something that lacks an important B-cell marker, which is CD20. So that's the important thing to remember, because there's a lot of epigenetic events that happen in these Hodgkin cells that prevent the B-cell transcription to occur properly. And pretty much the only B-cell marker that Hodgkin cells pick will be like PAX5, which is again a B-cell transcription factor, very important for B-cell development and B-cell commitment and maintenance of B-cell identity. So PAX5 is a totally different story, and it's a critical marker. So, so let's summarize what we knew up until 2000. Yeah? So Hodgkin has few cells. It contains a milieu of mixed inflammatory cells, and there are scattered Hodgkin-Leigh-Sternberg cells. Yeah? So the milieu is equally important as are the morphology of the Hodgkin cells. And Hodgkin shows diminished B-cell phenotype thanks to epigenetic downregulation, which leads to decreased or absent CD20 and expression of weak PAX5 along with strong CD30. Strong CD30 is pretty uniform in classical Hodgkin lymphoma, and it is very definitional. So you cannot call something classical Hodgkin if 30 is negative or wimpy. So you have to be careful on that front. And then as time went by in these 80s and 90s, they saw some Hodgkin cells cases that had more Hodgkin cells than usual. Sometimes they would see sheets of Hodgkin cells in some cases with anaplasia and sclerosis. And then studies were done, and they decided to call it grade 2 nodular sclerosis. And as pathologists, we like to create grades out of nothing. I know that anatomic pathology has a lot of grading, but in heme path, we don't very much have grading. But here is one area where we had this grade 1 and a grade 2. And the grade 2 got to be called a syncytial variant, as I've shown here. This is your classical Hodgkin with the milieu of Hodgkin lymphoma and the immunohistochemical phenotype of Hodgkin lymphoma. For the IHC, I pretty much use CD20, 30, and PAX. Yeah? And then there were these cases of nodular sclerosis grade 2, where you have tons of Hodgkin cells, all the allies, but otherwise the immunohistochemistry is the same, and the milieu is still there in the background, except that there are just too many Hodgkin cells there. And we also knew that NLPHL is distinct from CHL, and it's a different disease, and it has frequent relapses, but regardless, it has good outcome, and we tend to observe NLPHL for the most part until they're really symptomatic disease. So this is all we knew up until 2000. So this all seems nice. And then there is a lot of controversies around this grade 2 business. So obviously we like to do survival curves, grade 2 nodular sclerosis versus cases that have few large cells. And I don't need to go through all of these studies, but I will tell you that after the original studies describing nodular sclerosis by Strickler and Bennett, there's a whole bunch of people who looked at 7 cohorts of Hodgkin lymphoma patients, and one study said it mattered for outcome, one study said it doesn't matter, and one cohort said in the 70s patients, it was adverse, whereas if you look at the cohort from the 1980s, nodular sclerosis grade 2 does not matter. And so a lot of confusion came about nodular sclerosis. And things started getting a little more confusing, even though there was some clarity in the 90s. So normal CHL expresses weak to negative CD20. So this is what we learned. I told you that. Right. So what happens is suddenly CHL decided to express strong 20. So that's where a study came about in the early 2000s, after 2000. So the CHL and the CHL with strong 20. What do they mean and how does it impact prognosis? So this is a study that came out of the UK. And here they decided to look at the adverse prognostic significance of 20 positive Reed-Sternberg cells in classical Hodgkin's disease. Yeah, they still call it disease. So it was not a lymphoma, I guess, at that time. Yeah, Samuel Wilkes actually called them Hodgkin's disease because he had no clue whether it was a lymphoma at that time. So here is a picture from that study showing scattered Hodgkin cells, and this is CD20. And as you can see, the 20 is pretty strong. The cells are few and far, but this 20 is pretty strong. And these were 30 positive, I presume. I don't have much of the pathology data and what central review was done, but this was back in 2004. So that's that. And sure enough, they show survival curves for overall survival showing an impact for adverse prognostic impact of CD20 expression. This curve going down, the Kaplan-Meier plot is the CD20. So then people started thinking, CD20 expression is bad, so it must mean something. So this kind of threw a wrinkle in our knowledge of classical Hodgkin lymphoma, where B cell markers usually are downregulated. Now, how does this happen? What's the biology? Things get confusing. So then let's go on and try to increase the confusion that started in the early 2000s there. So again, back to the left, we see Hodgkin's expressing classical Hodgkin with typical phenotype, few cells. Nodular sclerosis with typical immunophenotype, tons of cells, which is controversial as far as prognosis goes. And then you have the 20 positive classical Hodgkins that were described by the Portlock study. And again, the immunophenotype based on that study was mostly okay, except for the fact that 20 is off. So that's a bit in red. Now, we will add a fourth element over here that came to be known after the early 2000s, which is DLBCL and PMBL. There are two entities here that I'm talking about, where there are sheets of tumor cells. So my cartoon there is sheets of tumor cells that are centroblasts in morphology. And in early 2000, we got to learn about the molecular biology of diffuse large B-cell lymphomas into germinal central phenotype and non-GCB. And we have centroblasts like that with multiple 3 peripheral nucleoli. And then they started describing cases of primary mediastinal large B-cell lymphomas that seemingly arise from thymic astroid B cells. And strangely, when you biopsy them, they would have this kind of compartmentalizing sclerosis and nests of tumor cells in the compartmentalized areas. So that kind of was an interesting thing, but how does all of this relate to the realm of Hodgkin lymphoma? So that's the next question. So to explain that, let's see a case. So this is, to the left, a H&E showing your primary mediastinal large B-cell lymphoma with nests of tumor cells. You barely see cell borders here in this lymphoma, and this is very typical of PMBL. This nesting sclerosis and tumor cells that are floating in a sea of cytoplasm. And that expresses strong 20 and strong diffuse 20 with numerous tumor cells is something that you see in diffuse large B-cell lymphoma. Yeah, and it expresses CD30 to a good extent, and not as strong as classical Hodgkin, but it does express 30, and that resembles CHL. So now this throws a wrinkle in our knowledge of a phenotype of classical Hodgkin versus a diffuse large B cell expressing strong 20. And it also expresses CD23, which we don't know what it means, but we won't get into much of that. And of course, there's some more things about mediastinal large B cell lymphomas, that they are also defective B cells and cannot make immunoglobulin. This kind of sounds like Hodgkin lymphoma, and it almost sounds like lymphoblastic cells, which also cannot make immunoglobulin. And yet, it's positive for these B cell markers up to BOB1 and CD79A, which is actually the tether for the immunoglobulin molecule on the surface of the B cell. So far, so good. So this slide is a busy slide on biology, but suffice it to know that CHL and primary mediastinal large B-cell lymphoma have similarities. I will just point one thing for you. One thing that is relevant in the current day and age is gains on 9p, which is where you have JAK2, and of course there's also PDL1, which is so popular these days, which is also there. And so these two are kind of common for both CHL and PMBL, and therefore there's some similarity at the biologic level between these two entities. There's lots of studies that have shown that methylation profiling also there's overlap in these two entities. And so there's a lot of interest in knowing how these two tie to each other. So that became even more interesting. And so we recognized that there is not only classical Hodgkin lymphoma, which is 20 negative and 30 positive, but also a PMBL, which can be 20 positive and weak 30, which overlaps Hodgkin's. And the PMBL, because it has sheets of large cells, overlaps diffuse large B-cell lymphoma, which is also 20 positive and usually 30 negative. So now you can see that some things are a continuum and not really two distinct entities. So to go further, let's see if maybe we learn 4 different entities here, and maybe there is a missing link or a continuum in these biologic features. And at this point, I will also reiterate that as we progress from Hodgkin to these entities, the 30 keeps decreasing. And as we progress from classical Hodgkin to diffuse large B-cell, the amount of CD20 keeps increasing. And it's also good for fourth-year med students to know, and of course pathologists too for that matter, that Hodgkin, the typical frontline, they use ABVD times 6. That's your classic therapy that they use for frontline settings. Whereas for diffuse large B-cell or PMBL, they would pick something like R-CHOP. So it's always good for us as pathologists to know the basic treatment regimens that are usually prescribed in patient populations. And of course, for PMBL, they choose more aggressive regimens like EPOCH-R, but this is not a talk on the oncology choices. So with that said, maybe there's a missing link that we need to know, and that's where we come to learning about certain other kinds of cases that we've seen between 2000 and 2005. So to illustrate one situation, I will show you a case that one of my former fellows, Mir Ali Khan, who is now attending at a nearby hospital, sent across to me. So this was a 24-year-old woman with a bump in the clavicle, with difficulty in breathing for 2 months, and a CT scan was done, and it showed an 18 centimeter mediastinal mass. Okay, this presentation is perfect. Yeah, and there was cervical and abdominal adenopathy, and they decided to do a mediastinal biopsy. So obviously, when I go for lymphoma workups, I try to make an a priori decision about what all things could be based on the location. Based on age and location, your first choice is probably going to be a Hodgkin. Classical Hodgkin is very likely. And of course, if you have a second choice to offer, you're going to think of maybe a T lymphoblastic process. And as a third line, you could think germ cell tumors, but they are much less common, or thymoma for that matter. And I'm not a radiologist, but I have tried to pull this and mark the areas where there's lymphadenopathy. Yeah, this is supposed to be lymphadenopathy there, and radiologists accuse me of this as unarmed lymph nodes. So under the microscope, when you see there is compartmentalizing sclerosis, yeah, we can see that there is fibrosis there is nodules, and we don't really see cells here at this power. So we cannot quite jump to say that this is Hodgkin lymphoma. And then when we look at higher power, we do see that there are sheets of cells over here. And this doesn't quite fit with our dichotomous schema of few large cells in a sea of normal. And as you look at higher power, the cells are even uglier, and they look bizarre, some of them like that, and they look pretty Hodgkin-y though, some of these cells with prominent nucleoli. So it does create a little confusion for us. There is eosinophils, so the environment seems perfect. Yeah, so far so good. And maybe in that 4 boxes that we had, nodal sclerosis seems reasonable. But again, you do need immunostains to get to a diagnosis here. So let's see how we are on time. 9:36, so we're not too bad. So now this is CD20. And of course, I like to look at my internal controls, which are your background small B cells. Small B cells are positive. And do we see a Hodgkin cell? Yes, there is a wonderful Hodgkin cell there sitting, and it's negative. Obviously, it has a downregulated B cell program, so that's good. And this is CD30, and you can see that all the Hodgkin cells are diffusely positive for 30. There is even a Golgi pattern there. And these are your normal lymphocytes in the background. And these, any area, anybody knows who these cells are? You can raise your hand at the stop maybe. If nobody answers, I'll just call on pathologists. Okay, let's see more. There's some answer coming. Chat, let's see. Yes, that's correct. This immunoblast. Dr. Jassim is perfect. Those are immunoblasts. Always remember, immunoblasts in Hodgkin lymphoma are always there in the background on CD30, so never confuse those. So this is CD15 right there, and CD15 is positive. CD15 is a tricky stain to interpret. You have to be careful. The staining is very punctate, granular, and you can see the CD15. This one is easier actually. I'm not sure why I use that arrow there. And you use your internal controls, and here we actually see the bulk of the cells are monocytes. This 15 work well. And there is weak packs, and these strong packs are your normal B cells. So this is perfect for classical Hodgkin lymphoma, right? Let's keep going. And of course, we did some more stains. This was in retrospect. So this was not done at the get-go. And these are not necessary either. So here you see BOB1, which is a B cell transcription factor, is negative in these cells. And these are your normal cells, B cell staining for BOB1. And this is at a much higher power. And you can see a Hodgkin cell that is almost negative or maybe weak positive for BOB1. But honestly, I think this stain is a little suboptimal because I'm seeing that normal T cells are picking very little BOB1, which is a typical feature of a degrading antibody. So this is in my lab. I need to change my own antibody here. Okay, this is also a nice cell that people should learn to recognize in lymph nodes. Any idea what this cell is, this negative cell that I see here? It's a normal cell, I'll tell you that much. Yes, Dr. Jassim, or maybe Alanandal, you want to take? Perfect. Sarah has said that it's a dendritic cell. She's exactly right. This is a follicular dendritic cell, and that's how it looks. 2 nuclei touching each other like that. And these cells are often confused in follicular lymphoma, where you have a lot of dendritic cells in the lymph node, and people get confused and grade them as centroblasts. And so you will overgrade your follicular lymphomas if you don't know to recognize your FDC or a follicular dendritic cell. They're usually doublets like that, and it's often called kissing cell. So coming back to our diagnosis, we are nodular sclerosis, classical Hodgkin, increased Hodgkin cells, perfect diagnosis. Everybody's happy. And then the treatment is given. Yeah. And obviously they do 2 cycles of ABVD. And yeah, there are some protocols where they do a PET after 2. And when they did that, they saw mediastinal mass, SUV has come down, but there's still a persistent disease there. And there's other sites of adenopathy disappeared on scans. So that has been response, so that's good. And for whatever reasons, I'm not sure, they went ahead to give 2 more cycles of dose-escalated BIACOP. I really have no idea why this was chosen. It's usually used more often in the German studies. At any rate, the PET scan continued to show uptake in the mediastinum. So now that became worrisome. So I guess they repeated PET after 2 and then again a PET after 2. And then they saw uptake and they were worried. And because things were not going well. So they went, there was a huge chest wall mass that popped up. And they went and biopsied that chest wall mass. Remind you, this was earlier in the mediastinum. And so this is pretty much at the same site, what's happening. And the chest wall mass looks like this. We really can't see much, but it doesn't look like there's compartmentalizing sclerosis at this power. And then we look higher, and then we see sheets of large cells. And they look large, multiple small nucleoli, yeah, like that. They don't quite look like those Hodgkin cells that I showed you earlier. And they are not few and far. There's sheets of them. This is not good. And then stains were done. The tissue was suboptimally fixed, so the stains are not optimal here. But you can see that CD20 is diffusely positive in all the cells. And CD30 is also diffusely positive. It's kind of wimpy, but it's there. There's more than enough 30 over there. So that throws a wrinkle for us. And CD15 here is staining the neutrophils, and the main cells that are lymphoma cells are not staining for 15. And Ki67 is strongly positive with numerous positive cells, which this is a lot. Normally we don't do Ki67, but if we have a sheet-like proliferation, we like to do Ki67. And then for whatever reasons, we decided to do OCT2 and PAX5, because if this was indeed Hodgkin, the OCT2 and PAX5 should be negative or something. The 20 itself was becoming positive, so things are getting out of control and not adding up to the Hodgkin relapse or a persistent Hodgkin. And OCT2 is strongly positive, PAX5 is strongly positive. So the B cell identity is really nicely maintained, which is not good for Hodgkin lymphoma, classical Hodgkin rather. And so here is where we have to entertain the diagnosis of a gray zone lymphoma between diffuse large B cell and classical Hodgkin lymphoma. And sometimes gray zone lymphomas will also overlap PMBL with the 20 and the WP30. It often overlaps that. So this is a typical setting where the case probably started out as a composite gray zone lymphoma. So we'll discuss some of these gray zone lymphoma types as we go in the subsequent studies. So this is a typical gray zone lymphoma where you have sheets of tumor cells and they don't quite have the microenvironment of classical Hodgkin. And like eosinophils, plasma cells, sclerosis and all that. And when you do a CD20, sorry, this is CD20, they are negative for 20. And this is CD30 on C, is strongly positive, and 15 is strongly positive. Yeah. So sometimes, with just based on morphology, you can say that it looks like DLBCL or PMBL, but IHC actually matches for Hodgkin lymphoma. So this would fit for what we would call as gray zone lymphoma. This is important to recognize this spectrum of what can be called gray zone. Not all gray zones will be positive for 20. So a study was done. This is one of the index studies that came out of NIH, by Dr. Jaffe's group, where they described these gray zone lymphoma cases, how they present. And so they found cases, 21 cases where you had histology that was atypical, either for Hodgkin or large cell, and the IHC was concordant, or both the histology and IHC was discordant. Yeah, and they had 6 cases where this was synchronous or composite Hodgkin/PMBL. So that is, you had areas of PMBL in the same biopsy along with Hodgkin, or you had the same patient had PMBL in an axillary node and maybe Hodgkin in the mediastinal location. And so when you have 2 different lymphomas at the same time in one patient with different morphology, then you're better off calling that a gray zone lymphoma. And of course, there are 9 cases of sequential where the patient had Hodgkin first and several, maybe after treatment, there was a relapse or a persistent disease that showed PMBL. And of course, vice versa, you can have 2. So this is important to recognize that they may be composite lymphomas or they could be sequential. So they can be either way. So you just have to be able to put it together as a pathologist. And this is a spectrum showing one case where you have what looks like sheets of lacunar cells. And this funny sclerosis and compartmentalizing resembles primary mediastinal large B-cell lymphoma. And the 20 is weak here, and the 30 is wimpy. This is not your 30 that we expect for classical Hodgkin. And this 20 is too little for a PMBL. It should be strong 20. And this 15 is really strong and good for Hodgkin, but it's not something you should be seeing in PMBL. And then we see the B-cell markers of BOB1, which is negative. So PMBL cannot be negative, but Hodgkin classical can be BOB1 negative. And PAX5 is weak in these cells, which fits for classical Hodgkin, but not for PMBL. So every stain you look at, it fits one or the other. So when you have this bobbing like that between morphology and IHC, and you cannot make up your mind, you're probably better off calling it gray zone lymphoma. So it typically occurs mostly in males. Yeah, and most of the patients turned out to be males, and of course, at least half of them will have a CHL morphology. So you have to be careful when you're looking at Hodgkin's to see if you could get to gray zone based on the morphology. There are clues, there are clinical clues, so you have to use that clinical clue. Let's not get into POO1 and stuff like that. I'm going to skip that part for now. So summarizing all of this, so we learned about the milieu business, we learned about the CD20 pack status and the 4 subtypes, yeah, classical Hodgkin lymphoma, and the nodal sclerosis variant with lots of cells, and then the 20 positive Hodgkin lymphomas that's published by Portlock that did worse with Hodgkin therapy. And of course, we don't know what these 20 positive Hodgkin lymphomas really are because those cases were not vetted and we don't really know what they are. And of course, you have your DLBCL/PMBL, which typically have the morphology and immunophenotype of diffuse large B-cell lymphomas. And then we learned about gray zone lymphomas, which are more aggressive and are better treated with a stronger regimen like EPOCH-R. So these are the 4 things that we have learned today. So with that said, I will briefly mention the entities that can be overlapping and confusing that you should remember that I have not discussed further in this talk. So you have a diffuse large B-cell lymphoma, the classical Hodgkin lymphoma. These 2 can overlap, and that's where your gray zone lymphomas come. And we learned about the Hodgkin's that the strong 20 that overlaps Hodgkin. And one more entity that we have not discussed, or we've discussed earlier, is non-lymphocyte Hodgkin, which can progress to a T-cell rich large B-cell lymphoma. So this is an entity with few large 20 positive B cells in a CF normal. So T-cell rich large B cell follows the commonality of few large cells like Hodgkin lymphoma. It's possible that the cases of 20 positive Hodgkin lymphomas that the BJH study showed probably include some T-cell rich large B-cell lymphomas by mistake. And maybe they were better off to be treated with a CHOP-R-based regimen. Now, with that said, there's one big area that we haven't discussed, which is EBV. So EBV can pretty much be present in all of these lymphomas. So EBV can be present in classical Hodgkin and can be present in cases that we call T-cell rich large B-cell lymphoma in the past. But once you have EBV, you designate them as EBV positive diffuse large B-cell lymphoma. Especially if 20 is strongly positive and there is EBV, you're better off calling it an EBV positive large cell and treating it with the CHOP-R based regimen. And once you talk EBV, there is a third entity called LYG, or lymphomatoid granulomatosis. There's always this tongue twister. Lymphomatoid granulomatosis, lymphomatoid papulosis, and then there's one more thing in the colon. Anybody? That sounds similar? Sarah, Jason? That sounds like a tongue twister. A variant of mantle cell lymphoma in the colon or ileocolic region. Okay, nobody? Lymphomatous. Lymphoblastic blastocytoma, that's probably an older name, but maybe not. Papulosis, yes. Lymphomatous papulosis, lymphomatous polyposis, sorry. See, I'm forgetting my own base. Polyposis. So mantle cell lymphoma can present like polyps in the ileum. So that's called lymphomatous polyposis. Okay, so that's good. And so, okay, I threw a barrage of things onto you right now, and you must be tired. So I'll do a couple of slides, and then we will do some unknown slides. Yeah. Okay, this is my approach. Okay, this is good for pathologists too, and it's a very simple algorithm. You assess the tumor cell content when you look at a biopsy, and if it is tumor cell rich, try to make up your mind what it resembles. Does it look like CHL, or does it look like PMBL with its compartmentalizing sclerosis, or does it look transitional with scattered Hodgkin cells and some sclerosis and too many tumor cells? And then you look at the phenotype of 30 and 20. Yeah. And if they are green, they are very positive. And if they're like this, they're hybrid. So look at the status of that. 30 and 20 are strongly positive. It's probably a gray zone lymphoma. If there is variable 30 and variable 20 in something that looks transitional, go to gray zone again. And if it looks like PMBL and it has strong 30, but it totally lacks the 20 that you expect for PMBL, go to gray zone. I showed you a case like that earlier. And of course, if you have 30, 20, and 15 all at the same time in something that looks like PMBL, go to gray zone. And if it's tumor cell poor, don't try to entertain the diagnosis of gray zone lymphoma. More than half the time, people who make a diagnosis of tumor cell poor cases as gray zone are wrong. It will go to a second institution, and if it's an expert, they will not believe in gray zone lymphoma. There's been a study that's been shown the tumor cell poor cases have a high likelihood of not being called gray zone on expert review. So if it's tumor cell poor, again, the same markers will help. Strong 30, variable 20, make sure you do the EBV. EBIRD is good. RNAi instructive hybridization right there. EBV positive classical Hodgkin. And if it's 30 variable and strong 20, so then look for, you entertain a possible diagnosis of T cell rich large B cell, and if the same thing has EBV in it, you call it EBV positive large B cell lymphoma. Yeah. So I'll share this paper with you guys later, so you don't really need to make a note down the line. And with that said, any of you have any specific questions related to this area before we go on to our unknown slides? Okay, if there are no questions, you can always email me if you have specific questions relating to pathology. But let's go to the unknown slides, and let's see. I hopefully have enough time. Yeah, I'm good on time. Why not? Okay, so this is a 29-year-old male with a non-healing oral ulcer, and he reportedly had a sarcoma excised a few years ago. And I think even the history itself has a lot of clues to the diagnosis. So does anyone want to venture a diagnosis? Just based on the history? Feel free to. I can always look at it in the chat session out here. It's okay. I will only call out the right answer. So that's that. And with that said, I will go on to show you what the biopsy showed. This is what came to me earlier. And this is the H&E showing a squamous epithelium right there. And there seems to be some infiltrate in the subepithelium. Okay, there are some really nice choices coming up in the chat. That's almost right there. Yes, EBV mucocutaneous ulcer. Okay, that's a wonderful chart. Let's keep looking and maybe we can get to a diagnosis there. This is the H&E showing sheets of large cells. I wouldn't say large, I'm sorry. At low power, I'm only able to say that there are sheets of cells there. That's all I can say. So you have to make your morphology commensurate to the power. And when you go at higher power, you see even more cells over here that look bad in some ways. The big question first is hematopoietic or not? Yeah, that's the first question everybody has to ask. Just because I'm a hematopathologist and showing you this case doesn't mean this has to be a hemopath-related case. So keep that in mind too. And then we see cells like these. I don't know, are these small, medium, large? They look large, right? Yeah. We always use a reference for what is normal. And we use these internal lymphocytes as our normal. And by the size of the lymphocytes, these are large cells. And this is what it shows on higher power. They look bizarre and ugly looking. And then we look further, there's mitosis there. This is highly proliferating, so this is not good. And then we keep looking. There are cells like these. Hematopoietic or not? Any charts? Anybody? Or is it a carcinoma? No? Okay, let's keep going. This is CD20. Okay, we already have the right answer there from Dr. Sigamani, but I'm not going to spell it out. So this is CD20, which is negative, and there are scattered small B cells. So there's also an art to microphotography. So when you take pictures as pathologists, you have to make sure that if you're showing a negative stain, make sure that you have your internal controls lined up in that same field. Otherwise, you never have credibility for your stains that they worked. So, so here the CD20 is staining the small B cells in the background, but the tumor cells are negative. And this is some nucleolar CD20 that you frequently see because of secondary antibody binding to histones. This is non-specific staining, and do not construe that dot-like nucleolar staining as positive. Just a tidbit for pathologists who do immunohistochemistry. There's also some thought of calcium features from someone else. Let's keep looking. So yes, so there's certainly something that catches the eye. CD3 stains the background T cells. The cells of interest are negative. So always, when we describe stains, make sure you refer to the right population along with your internal controls. This is BCL2, and I have no clue why BCL2 was done. And yes, Sarah has also come up with the right answer, the perfect answer actually. And yes, numerous people have come out with the right answers. I will name all of you down the line. So BCL2 is weakly positive in the lymphoma cells, and this BCL2 is staining what cells? Anybody? What is the internal control for BCL2 here that I am seeing? Shut up. Maybe you want to take? Okay. Okay, Dr. Sigani is saying T cells already. So that's wonderful. So BCL2 internal control, T cells. So we always think follicular lymphoma when we say BCL2. But remember, normal T cells express BCL2. And this is c-MYC, is strongly positive in quite a few of those ugly looking cells. And this is a marker called MOM1, which stains plasmacytic cells, and MOM1 is strongly nuclear positive in these cells. Ki67 is strongly positive in these cells, it's highly proliferative. And 138 is also positive, as some of you expected. And this is kappa and this is lambda. So the kappa is strongly positive, the lambda is negative, meaning they are kappa restricted plasmacytic cells that look ugly and immature looking. And this is EBV, that is EBV in situ hybridization, staining the nuclei of all these cells. So this is indeed EBV driven. And obviously, the answer is, as Sharav, Sarah, and Dr. Sigamani got it right. HHV8 negative, and this is PDL1. So let's look at PDL1. Anybody want to say what's staining here? The cell that's positive? So that's a histiocyte that stains with PDL1. So that's your internal control for PDL1. And of course, there is a lot of tumor cells in the background that are negative for PDL1. So always remember, your internal control histiocytes must stain when you're doing PDL1. After this case, we'll take one question that Nicholas has. So that's your histiocyte. Yeah. So this is oral plasmablastic lymphoma, as all of you said, right? It's in a HIV positive male who had Kaposi sarcoma. That was a sarcoma history in the remote past. Nobody told me the history of HIV, so it's always good to check on the history. This was from an oral surgeon that sent the biopsy, and I was surprised to say that it was lymphoma. 20 may be negative in lots of proliferations, so think to do 138. And the lack of 20 would be odd for EBV positive DLBCL. Yeah, so you have to think of that too. So you shouldn't make a diagnosis of EBV large cell. And so PDL1 stains histiocytes. That's one thing we learned. And when you do EBV RNA in situ, it comes with 3 slides. You have to look at the negative control. You have a positive control, like you do in immunohistochemistry, and you have a U6, which is a control for the RNA itself. Since all RNA have a poly A tail, you put a probe against the poly A tail to make sure that the tissue of interest actually has intact RNA when you do the RNA in situ. So that's why you need to remember this point. So with that said, let's take a question that we have. And yes, Sarah mentioned HIV. Yes, that's correct. And Nicholas here asks me, in the last chart you showed with tumor-rich and tumor-poor EBV correlation, and wouldn't NLPHL also come in the differential of these tumor entities? Yes. So you are right, NLPHL would come in the differential of those tumor entities, but we are talking about aggressive large B-cell proliferations. So NLPHL doesn't necessarily come in the context of aggressive large B-cell proliferations. We do think of borderlines between NLPHL and T-cell rich large B-cell lymphoma. When NLPHL progresses, that's when we start thinking of these progressed entities. So the chart itself is a large chart, so I didn't want to confuse this further with adding NLPHL into that equation. But yes, the borderlines between NLPHL and T-cell rich large B-cell, it's a totally different discussion. We don't have time for that, but certainly we can discuss that gray zone in a totally different topic. So that's wonderful. Great answers, all of you. And let's move on to the next case. How are we doing on time? 10 o'clock. Good, good, good. 20-year-old female with a biopsied neck lymph node. Okay, so low power is important. We all like to see low power. There is no semblance of normal architecture. There is a funny mottled appearance, right? Yeah, there's some vague nodularity perhaps, but I don't see anything obvious here. I'm trying to apply a rule of few tumor cells versus sheets of tumor cells, and I don't know where this fits. And looking at this power, do we think there are few tumor cells there, or is it sheets of ugly cells? Any thoughts? Anybody? This is actually a slam dunk case and a straightforward case. So yeah, we do see some cells there that are funky looking. So we already have an answer there, as I expected, from a pathologist from CMC, who I'm not going to name now. Okay, let's keep looking. Okay, one more person from CMC is telling me the answers. Okay, these are folded looking cells, yeah? And they have small nucleoli, multiple folded nucleoli, as nuclei, potato-like nuclei, small nucleoli. And we obviously need to confirm the phenotype. So let's look at it more. So I'd like to keep looking at these cells, and that does remind me of popcorn. So I hope a bell goes for you in your minds, my students. And this is like 100x or something. I never take 100x in lymphoma, but one of the rare photos. This is CD20 showing nodules of what look like small B cells with large B cells sitting inside the nodules, something that Dr. Dekanha was alluding to earlier, why this wouldn't figure the definition of the entities. And this is another nodule with large cells. You have to pay attention, and then you see the large cells there. And this is high power, and then you can see the large cells there. This is even better, and you can see a large cell, a rosette of negative cells, and then small B cells. So that's a pattern that you recognize when you look at the 20. CD3, lots of T cells, and these T cells seem to be surrounding the cells and forming rosettes. Yeah, but these are not Flexner-Winterstein rosettes, as we know. Yeah. So this is CD3 showing the rosettes. This is OCT2, which stains the B cell over here, and you can see that the funny-looking cells are picking OCT2, and they are sitting inside nodules of small B cells. So this is a textbook picture, and this is a textbook picture of the same entity with nodules of small B cells and large cells sitting inside those nodules. They are ready to burst out, and they will soon make all the small B cells disappear. What was the history? Was it long-standing? That's one of the questions from Dr. Sigamani. You know what? I honestly don't remember. I think this was an isolated lymph node in a younger patient. How long the history was, I don't have an idea, but it was limited disease. That much I can tell. Just to the neck and nothing else. And the patient was just observed, to my knowledge. And this is OCT2, and this is more on OCT2 showing the large cells that are positive, and this is a degrading OCT2 antibody. You can say that because the T cells are picking weak OCT2. These are the rosetting T cells. They should not be staining with OCT2 at all. A good antibody should be dead negative in those cells. So I changed my OCT2 after I signed this case out. So obviously you had the diagnosis there, and of course, wow, okay, that's good. There's a lot of nice answers there. Dr. Sigamani, of course, Dr. Dakanha, yes, and of course, both of you are right, indeed. Nodal lymphocyte predominant Hodgkin lymphoma, and is the typical variant. So this is the new thing that we have to say these days, whether it's typical variant or not. The typical variant has nodules rich in small B cells. The variant pattern has nodules that doesn't have those small B cells and has mostly T cells inside the nodules. And that's what becomes bad and progresses to T cell rich large B cell lymphoma. And of course, Sharad has said CD57 and PDL1. So that's a good thought. CD57 is usually positive in the rosetting cells. Yeah, and PDL1 staining is not really relevant in this setting, but I'll tell you that PD1 is usually positive in the rosetting cells in this entity. Okay, this is a very straightforward case. A pediatric patient with 2 serial smears. Okay, we'll go fast on this case. We are getting to the time limit. Okay, anybody want to guess with just this history? If I'm going to show you 2 smears in one patient who is a pediatric peripheral blood smears, anybody want to take a guess? Let's see if an answer rolls out. Because this is a very leading history that you see. This patient's first smear was at day 3, and the second smear was at day 28. Okay, no answers. Keep thinking, and I'll start showing the case. So at, okay, this is day 6. Okay, I was ALL. Yes, that's certainly a thought to think, but let's see the full case, and maybe you will change your mind. Okay, the 6 days of age, this is how the smear looks. I don't think we can really say what these cells are at this power. So we need a slightly higher power. And this is how the cells look. And sure enough, yeah, they look like blasts. And just looking at the cells is not going to tell us what blasts these are. And we do need to phenotype these blasts to know what these cells really are. There are two cells there, which we would call as nucleated red cells. Yeah, and there's a blast. That's our favorite neutrophil. These are also funky looking blasts. There is a large blast with basophilic cytoplasm with almost something that looks like blibbing. And there's some more blasts with high NC ratio blibbing. And this is our lymphocyte there for comparison. So see the size, see the chromatin. There's a difference between the two. So you should be able to pick on blasts when you see them floating in the blood. Even if you're just a hematologist or just a medicine resident, it's good to be able to recognize lymphocyte from a blast. And more pictures of the same thing, a giant platelet, more blasts, and this is more blasts. Yeah, we like taking pictures of blasts. And so we need to phenotype the blasts, and this is how the blasts look. Yeah. And yes, Pratap is already asking leading questions. And yes, so this is 34 and 7. So normal T cells express 7. So these are normal T cells. And these are 34 positive cells, which are immature cells. And when immature cells with 34 express 7 dimly like that, that can never be good. And these are your background normals. And this is 33 and 117, which are myeloid markers. And the population that we looked at in red, that was 34 and 7, is carried over and seen here. And they express myeloid markers 33 and 117. So these are abnormal myeloid blasts. Abnormal because they express 7. So normal myeloid blasts don't express 7. So that's that. And of course, these are your normal neutrophils there. Yeah. And of course, there's one more 34 and 117 on the same cells for you to make it easy. And after 2 months of therapy, I don't have the day 28 smear. I had the post 2 months smear that I put here. And this is how it looks. Not so many cells now. Huh? And these are these lymphocytes or blasts? Anybody? So, okay, so these are just lymphocytes. Yeah, mature. Yeah, Sarah said that. Yeah, Pratap, Sudarshan Balaji, wonderful. These are lymphocytes. Yeah. So, where are the blasts? They've disappeared without any treatment. So, we get to the diagnosis. Anybody want to say the diagnosis? You guys have already said. Okay, there. Pratap has said the answer. I want someone else to say the answer. So, it will be unfair if I tell Pratap's answer. Dr. Pratap, sorry. Who else? Yeah. Okay. I'm going to just give the answer in the interest of time. Final diagnosis, transient abdominal. Oh, wonderful. Sharavan and Sarah said that. Down. Yeah, very good. Yeah, transient abdominal myelopoiesis associated with Down syndrome. Yeah. So that's the diagnosis. So learning points is it occurs in 10% of kids with Down syndrome, and it may be symptomatic, and present mostly with thrombocytopenia at first. Yeah. And the blasts have that funny basophilic cytoplasm, and they resemble megakaryoblast. They don't look like your average blasts. And phenotypically, they have very funny phenotypes sometimes. They have CD4, they'll have 61, which is the megakaryocytic marker, and of course, the 7 and 56. It's said that most Down's kid will have this myeloid stem cell phenotype with 7 and 56. That itself is almost diagnostic of Down. But obviously, with that, you cannot make a call of TAM, but you have to have this 4 and 61 at the time that you're making a TAM-based diagnosis in a patient with Down syndrome. So that's the important thing to remember. And of course, they have additional GATA1 mutations. Okay, so the truncated GATA1 will drive all this thing. So that's what happens in these patients. And that promotes megakaryocytic differentiation. And that's why you get these megakaryoblastic leukemias in Down syndrome. In about a third, you will have myeloid leukemias to develop. And when myeloid leukemia does develop, it happens quickly within 1 to 3 years after the TAM. And obviously you have additional mutations that acquire or need to be present before you go to myeloid leukemia and Down syndrome. So that's an important thing to remember. So do you know who had one of the first, who was the index patient that had Down syndrome and who that person's father was? It's just an interesting tidbit on Down syndrome that I came to know recently. The first described, it's actually pretty close to where you are, Pratap. It's in the UK, Charles Darwin. So his last kid reportedly had faces that resembled Down syndrome. So that was one of the first descriptions of Down syndrome. I can forward you all a really nice post that David Steensma posted. It was on Twitter. I read out that story about how Charles Darwin's last kid had these faces and he passed away. And they described how, and so years later, it was described by how Down was described and the concept of Mongolism and how Mongolism went out of favor and the discovery of GATA1. It's a fascinating story, but I can't dwell on the whole story right now. So yeah. So AML occurs within 5 years of age, megakardioblastic, and when leukemia does occur, it's often 34 negative. Yeah. So that's that. And the town in which Darwin lived was also called the county, or wherever it is. It's also called the Down County, and it was called the Down House afterwards. And then the person who described it also was called John Henry Langdon Down. So there's a lot of Down in the name itself. So maybe all the Downs came after his first description, for all we know. Okay, this is a spot the diagnosis moment right there. Who's going to say the answer? The first answer gets a shout out. How common is ALL and TAM? Sharaf, ALL is still probably much more common in ALL in TAM. No, not in TAM. In overall in Down skid, ALL is probably still much more popular. And of course, the first answer for this is from Sarah. She said the answer, sickle cell. That's perfect. And there's one more, I can't say the name, Galaxy A24, who's correct. Jasim, yes, of course, Dr. Neelakantan, Dr. Balaji, all of you are right. Sickle cell. The sickle cells, that's all I know. I don't know if it's anemia or not, but that is, yeah. And of course, this is a bite cell right there. Sometimes you see bite cells in sickle cell too. When the spleen gets smaller and smaller and becomes hypofunctional, you will start seeing bite cells. Yeah. And of course, there are two questions here. This patient is post-allogeneic stem cell transplantation, day 80. And he had anemia. And the clinician came down and tried to ask me, why is there anemia? There should not be anemia. And he came and I pointed these cells to the clinician. Anybody, what are these cells? That should be easy enough. Perfect. Dr. Neelakandan has said the answer there. Galaxy A2 core, Redmi, schistocytes. Perfect. Yeah. So that's correct. Yeah, these are not exactly bite cells, but these are actually schistocytes or fragments. Okay. So how do you tie this in the immediate post-allogeneic stem cell transplant setting? How do you explain this? Is there something that you could use to explain? Anybody? There's a tidbit that I actually learned recently. Yes, Dr. Neelakandan said the answer. Yes. So immunosuppression induced TTP. Yeah. So they give tacrolimus for immunosuppression after stem cell transplantation, and tacrolimus causes dose-dependent schistocytes. So all pathologists who are looking at bone marrow biopsies in the first day 100 to 200 always look for these schistocytes and make sure you report these on your top line of the final diagnosis, because they will go back and scale back on the doses. This case wasn't as bad because the platelet count wasn't as low, but when the platelets and the hemoglobin are low, you should alert the clinician that you should see schistocytes, and they'll go back and do that. So that always makes you a little better in front of clinicians. So take home points. Hodgkin's may show numerous tumor cells, and that's a good panel to use. And I typically use this panel all the time. And PD1 and PDL1 are not really used for diagnostically. I never do them in Hodgkin lymphoma. except when people are doing research and they ask for specific stains, then I'll do it. Most Hodgkins will show PD-1s in the background. Look for the extent of B-cell marker expression on the Hodgkin cells. If it's too strong and too many B-cell markers are positive and it's relapsed disease, think of Gray zone lymphoma. Even if someone has called it Hodgkin on the outside, rethink their diagnosis and possibly think of a large cell lymphoma with 30. And think of always doing EBV. And if you have EBV and strong 20, you might be dealing with an EBV positive large cell lymphoma, which is better off treated with R-CHOP and not EBV. And if the background of the whole section is very vascular and it's a relapsed disease or is extranodal in an older patient, you also have to think of angioimmunoblastic T-cell lymphoma in those settings. Flow is really not useful, except when you're thinking of a possible T-cell process, because in angioimmunoblastic lymphoma, you will have 3 dim T-cell populations that circulate in the blood. And that might be useful when you're distinguishing angioimmunoblastic from Hodgkin lymphoma. And numerous PD-1s in the background does not automatically mean T-cell lymphoma. This is a misconception that many pathologists have. And you might find T-cell clones, and that doesn't mean anything at all. Most CD4 T-cells that you see in Hodgkin backgrounds tend to have PD-1, or even not a lymphocyte Hodgkin for that matter. And so now this is a small note for clinicians who read the path reports. And these are smart questions that you can ask pathologists in primary refractory cases and cases that have atypical presentations. Are you sure this is not Gray zone lymphoma when you see that's kind of a strong 20 that you put in your report? Did you check for EBV in that case? Sometimes pathologists forget to do EBER. So did you check EBV? Maybe this is an EBV positive large cell lymphoma. That's something to think. Are these really Hodgkin cells or Hodgkin-like cells in your report? So see what the pathologist is using for those Hodgkin cells. Sometimes they'll get away with saying Hodgkin-like cells, which means they're hedging. And are you sure that the 30 positive cells that you're reporting in your report are not just reactive immunoblasts? Be very careful about that, because EBV reactivation can be mimicking Hodgkin all the time. I have not discussed that, but that's something to think. And one more thing that I face time and again is from cytology. This is my own people. They always think that Hodgkin is a diagnosis of morphology, and Hodgkin, you should not be doing immunostains. And for Hodgkin, a needle aspiration is enough to make a call and start treating the patient with ABVD. This is a time-honored cliched statement that I keep hearing from them time again. No, you cannot make a diagnosis of even classical Hodgkin lymphoma without the basic stains. There's too many variations in Hodgkin's these days that impact treatment that an excision biopsy is critical. NCCN does strongly recommend that you should do a biopsy regardless. And just to tell you, these are the variations of cells that you should remember. Hodgkin cell looks like that. The popcorn cells of LP looks like this, potato with dots. Centroblast of large cells look like 3 small peripheral nucleoli and a round cell. The immunoblast that you saw in the plasmablastic lymphoma looks like that with prominent nucleoli. So that's the morphology. And we pathologists always try to get to the best diagnosis all the time, looking at cytology, the morphology, and things like that. And despite all that, we can still be wrong sometimes, and that's okay to be wrong sometimes. But thankfully for us pathologists, even if we are wrong, we get a second chance in the autopsy suite. That's the autopsy suite at UFC, where we do autopsies. And this is Halloween night, when we like to play movies in the morgue in Halloween night. Cheesy old-time horror movies. And that's my previous fellow, Megan Perla, who is now a fellow at MD Anderson. With that said, these are my mentors. Elaine Jaffe from the NCI over there, who was there for the honorary lecture for Dr. Vardaman, who is, all of these are people from the WHO book. He's a huge CML person and one of the editors for the WHO tumors. And this is John Anastasi, who worked with me at UFC. And that's me quite a few years ago. I'm a little plump there, but obviously you can see I'm not as plump these days. With that, I'll end the session and let's see what questions you might have. One of the questions I have here from Sharav is, how is Hodgkin lymphoma reported on cytology? Okay, so this is what I tell my cytologists. They will show the slide to me and they will say scattered large atypical cells, Hodgkin-like cells present, recommend excision biopsy. That's what I'll tell them to say and force them to do the excision regardless. So we are not supposed to give a confirmative diagnosis of Hodgkin lymphoma in a core biopsy. Sarah, so in a core biopsy, you can give a diagnosis of Hodgkin lymphoma. Definitely you can give the diagnosis. If the clinical setting seems okay, and if it's a superficial, if it's a deep node, that's perfectly fine. I would not press for a repeat biopsy. And obviously, you have to be empathetic when you ask for a repeat biopsy. If it's an older person, a really deep node, and you get a small piece of core biopsy, you're not going to go and ask for an excision biopsy. If it's a superficial node, and it's a young patient with like a 10 centimeter node, and they give you a core biopsy is not representative of the whole node. And if it's highly petavid or clinically not fitting, you're better off asking for a big piece or an excision biopsy, just so you know that you're doing the right diagnosis. Okay, so then, yeah, thanks. Okay, let's see, any more questions? Yeah, I think that's all. Yeah, thanks everyone, glad you liked the session. Yeah, if you have any more questions, feel free to email me. My email is there. You can always find me on the internet and WhatsApp, and even my Twitter page if you want to. Yeah, that's it.
Thank you so much, Girish. That was wonderful, and I hope everybody enjoyed it. And I'm sure it was so educational, and I'm sure the students benefited from that. And professors and teachers from both sides of the pond, please do come forward to get into these lectures more and sign up for these lectures. I'll be more than happy to hook you up. Thank you so much for being there and being supportive and encouraging. And thanks, GV, once again. It was great listening to you. Thank you. And until next time, October 17th, we have a lecture by Dr. Shankar Niranjan on renal topics. So that'll be good too. So looking forward to meeting you all there. Adios, amigos. Until then, thank you. Have a wonderful weekend. Bye-bye.
Yeah, you know, bye-bye.